It's a Herculean task for me to introduce our speaker. I have been able to introduce him a little bit on my status, but yet words have not been enough to introduce our highly esteemed speaker. Dr. Kenzie is not just a lecturer; he's a teacher, he's a father, and he is one that knows how to impart knowledge. Over to you, Sam.
This evening, we are discussing functional low vision rehabilitation in daily clinical practice. This is an interesting topic. So, without wasting much time, we'll quickly go straight into the discussion. Low vision is a pretty common condition in our society today. In fact, globally, we have about 68 million people that are down with the condition we call low vision, with about 45 million people totally blind today. The reason for this rising incidence of this condition is simply because of improvement in modern living. Today, we have technologies that have made life better and people tend to live longer. So as a result, the number of cases of low vision today is higher than what we used to have some decades ago. So it is even projected that by the year 2050, likely we are going to have double of this number. So we are expecting to have about double of 58 million people with the condition. And the cost, if you estimate what it costs to have low vision today, is about $45 billion. Now, this cost of this condition, what it costs having low vision globally, is expected to increase to about $376 billion. So, given this rising pace of the burden of low vision, it makes it necessary for optometry to advance in areas of specialty in order to meet the growing demand of vision care. So currently we know that in optometry we have about 7 specialties, and low vision rehabilitation is one of them. The reason for creating these specialties is to develop strategies that we can use to maximize patients' residual vision. Now, low vision, as we know, is an unpleasant condition that is chronic in nature. The condition has no cure currently. Someone that is down with low vision, there is no cure for the condition. It's a chronic condition that is uncorrectable, either by refraction, by drugs, surgery. None of these known remedies for eye problems can reverse low vision. So low vision is more or less an irreversible condition unless God intervenes. So what do we do to help our brothers and sisters that are down with this irreversible condition that impacts daily life activity? So this is where low vision comes in, where we develop strategies that we can use to harness the little vision that is left in such individual. Low vision is not the same thing as blindness. Someone with low vision is not blind. He's not blind, just that he has vision that is too low to meet his daily needs. Somebody with a condition that cannot support his daily activities is known as a low vision patient. So these people are not totally blind, but with deployment of technology and knowledge, we can harness the little vision that is left in them in order to improve their quality of life. So these people with low vision must have undergone vision screening and must have been diagnosed of one or more eye problems, and then they have been seen by a primary eye care specialist, the optometrist or ophthalmologist. They have been given the best form of treatment, which could be surgical, medical, or refractive, and yet their vision is very low. So these people, when they are sent to the low vision specialist, the low vision specialist carries out rehabilitation exercise in order to make the condition of the person much better. There are many eye conditions attributed to functional low vision. This includes cataracts, surgery complications, retinal conditions, including retinitis pigmentosa, age-related macular degeneration, retinopathy of prematurity. Then we have other conditions like aniridia. Aniridia is a condition where someone is born without the iris. Albinism is another condition that can lead to functional low vision. Glaucoma, brain injury, corneal opacity, uncorrected refractive error, optic atrophy. These are the major causes of functional low vision. Remember that I said these people with this condition must have seen the primary eye care optometrist who has done his best, has given the best form of treatment to this patient, yet the patient's vision is still too low for his daily activities. So this condition can affect people of all ages. Low vision can affect people of all ages, but the condition is more common among the elderly. Now, how do we quantify low vision? What kind of vision can someone have? And then we say this person has low vision. We categorize a patient as a low vision patient if after the best form of primary and secondary eye care, the patient's visual acuity is still less than is 18 in the better eye. In the better eye. All right. Can you hear me? I hope we are following.
Yes, sir, we are following.
Yes. Yes. So to quantify vision.
We are following, sir.
Before we can categorize someone as having low vision, this person must have undergone first form of eye care. Yes, the vision is still less than 6/18 of visual acuity, or visual field less than 10 degrees in the better eye. Normally, the average normal visual acuity is 6/6. But we are saying that if someone has undergone the best form of eye care, and yet the vision is less than 6/18, then we categorize that person as having low vision. Or if the visual field is less than 10 degrees, as against visual field, like vertically upwards, visual fields extend up to 70 degrees. Now, when this visual field is less than 10 degrees, we categorize the person as a low vision patient. That is after all the best form of eye care. So here, low vision is seen as any eyesight that ranges from moderate visual impairment to near total blindness. So functionally, today our focus is on functional low vision. And when we talk about functional low vision, we are not just interested in the patient's visual acuity in the clinic. There are some patients whose visual acuity in a clinical setting can do very well. You see them reading up to 618 in the clinic, but in their houses, in their places of work, where they do businesses, where they earn a living, that VA of let's say 618 in the clinic cannot serve them in their places of work. So when we talk about functional low vision, we are interested in that the level of visual impairment that hinders or that interferes with one's activity to perform his normal activities. So functional low vision simply means vision loss that interferes with one's ability to carry out his normal daily routine. So it's a very bad condition where someone that maybe the breadwinner of his family can no longer carry out his normal activity that brings money into the house just because he has an eye condition that makes that impossible. So we have some levels of care in the clinic, which begins with a primary eye care optometrist who examine this patient, and most times we find this patient to have a visual disorder. Visual disorder is a condition like cataract, an eye disease, cataract, glaucoma. These are visual disorders. Now, these visual disorders are diagnosed at the primary and secondary level. Now, when this visual disorder reduces the function, the visual functions, when a visual disorder reduces visual function, visual functions are things like visual acuity, color vision, contrast sensitivity, visual field. So when an eye problem or eye disorder reduces any of these visual functions, we say the individual has a visual impairment. Visual disorder is different from visual impairment, technically. But to a layman, we categorize everything. We use both words interchangeably, but they are not the same. Visual disorder simply means an eye disease, an eye problem, like refractive error, cataract, corneal opacity. So what does this corneal opacity, cataract, do? They cause what we call visual impairment, meaning that with these eye diseases, the person may not be able to appreciate 6/6 line on the visual acuity chart, or visual field is reduced, contrast sensitivity is reduced. So these are what we call visual impairment: reduced visual acuity, reduced visual field, reduced contrast sensitivity, reduced color vision, reduced eye movement. These are categories of visual impairment. This level of problem can still be diagnosed at the primary and secondary level. That is at the level of the optometry and level of the ophthalmology. Now, where the optometrist comes in now is at the level of visual disability and the level of visual handicap. We have visual disorder, we have visual impairment, we have visual disability, we have visual handicap. These are technically different terms we use in low vision. And in low vision care, our attention is on visual disability and visual handicap. This is the level of low vision care. So visual disability simply means what the visual impairment hinders the patient from doing. So if someone has low VA or low visual field or color blindness, and that color blindness makes it impossible for the patient to drive. Inability to drive due to poor color vision is called visual disability. So if I can no longer walk independently, inability to walk independently as a result of low visual field is another example of visual disability. Disability, something that you are not able to do because of visual impairment, is what we call visual disability. And then handicap. A patient is visually handicapped from societal angle, how people perceive him, the disadvantages, the economic disadvantage the patient suffers as a result of his visual disability is what we call visual handicap. For example, my patient some time ago came because he lost his job. This patient is a banker, but because of his eye problem, he was laid off. So loss of job as a result of visual disability. He can no longer operate his computer due to an eye problem inside that now led to his sack. That loss of job because of visual disability, we call it a visual handicap. So these last two levels, visual disability and visual handicap, is where low vision comes in. This is where we are much more worried. We try to tackle this problem mainly at this level so that these patients can return back to his normal activity. So the goal of low vision care is to restore the patient to his normal activity. If a patient is a farmer, but due to low vision, in low vision care, our goal is to make sure that we harness the little vision that is left in this patient so that this patient can return to his job. The patient can continue the farming work to earn a living. Even if we cannot restore the patient totally to ability to farm, but to an extent, this patient should be able to do it to earn a living from his job. So the goal of low vision care is to reduce the effects of handicap to the patient. Now, remember our topic again. We are looking at low vision rehabilitation in daily clinical practice. So when we have a patient that comes to the clinic with low vision, we carry out what we call functional vision assessment. We assess this patient's functional vision. And this assessment is a continuum. It's not just one test, one assessment we carry out. It's a continuum of care, which we carry out to unravel the cause or the causes of visual impairment that is affecting the patient's ability to engage his normal routine. In low vision care, we adopt flexible protocol. Unlike in regular optometry clinic, that is a bit rigid. In low vision, we try to be flexible to account for the patient's age. Like when we started, I told us that low vision is present in all ages, but the burden is more among the aged. So in our functional vision assessment in the clinic, we adopt flexible protocols to account for the patient's age, health status. Most patients with low vision are sick. They have debilitating conditions. So you can't insist on doing your ophthalmoscopy the way you do it in regular optometry clinic. You can't insist on doing your red at your TPCM arm's length. No, we are flexible in low vision examination protocol. Usually, we start our assessment by taking detailed history of the patient's case. We take our time to take history of how this problem started, how it progressed, what activities led to it, how it is affecting the patient. In fact, the whole clinical section for the day could just be on visual acuity, on case history taking alone. I mean, a clinical session. The first day the patient comes to the clinic can be dedicated just only for his history taking, because this is very, very vital. If you don't understand the patient's case very, very well, it will be very, very difficult to address the problem. So our assessment starts with history taking and then ends with the prescription of devices that will support the patient's daily activities. So our case history taking, when we are assessing the patient, I'm sorry I'm not able to share my slide, but Duru Franklin, if you are there, you can open, I think I sent you the slides, you can display it to them. So during our history taking,
we are seeing the slide, sir. We can see the slide.
Good. During our history taking, our attention, we ask questions around limitation of activity limitation. How is it affecting the patient's ability to cook? The patient's dressing. Can this patient dress himself? This patient, we ask about the social function. Can this patient still relate with friends? Or is the patient now in isolation? What about stigma? Is the patient facing some level of stigma? We look at this, then we focus also on the patient's mobility. Can this patient navigate his way from third floor to the ground floor unaided? Does the patient bump into things around? Does the patient have problems meandering through crowds? These are another area. Then we ask about reading, because in today's modern world, over 70% of the population are literate. So we do a lot of reading. So we ask about the patient's reading speed. Does the patient have any low vision gadget already? Does the patient need any technology to assist in reading? How is the patient's scanning ability to scan the page he is looking at? We'll ask around this. Then the emotional well-being. How is this patient coping with his or her condition? Does the patient feel embarrassed? Has the patient accepted his or her fate? Is the patient nervous? In fact, I had a patient yesterday in the clinic, though not a low vision case, but a patient that was referred from somewhere with a severe eye problem. You could see the woman is totally nervous, fear of blindness. And unfortunately, when we did our assessment, we found that this woman has end-stage glaucoma, which justifies her nervousness in the clinic. So we ask questions around this. We ask about driving ability. Can the patient still drive? Can the patient still move around? Is there history of accident? All these are things we record. So unlike in our regular clinic, where our case history notes is just maybe half pages, when you take low vision case history, you might write up to 5 pages, just case history alone. So because it is very, very vital. If you don't get enough information on how the problem started, you may not be able to address the problem. So when we take our history, we try to find out what the primary eye care optometrist has diagnosed the patient of. We ask about any history of surgery or treatment. We ask whether this problem has been stable. Is the problem stable, or is the vision dropping, getting worse with time? We ask about family history of eye diseases. Then we ask if the person has any device already, any spectacle already, contact lens, low vision aid. And then, very important, we try to know if the patient understands his or her condition and the implication. Because some patients, when they hear that you are sending them to a consultant, you know, that word, consult and honor. So when they get, they are coming to see a low vision expert. They are go away. So we try to find out whether they understand their condition. That this problem we call low vision is not we are just offering remedial measures that is so that the person can return back to functionality. The person can return back to his job. So you need to make this person find out whether the patient understands his condition. Then we try to find out about the reading ability of this patient. Is the patient having problem with seeing at far, seeing at near, or intermediate distance? Lighting requirements. So these patients have problem walking where there is enough light, or does the patient prefer staying? Try to find out. And also, some of these patients, their complaints is because of the nature of their working environment. So we try to find out the level of illumination where they work. Some are not aware in their house that is making their condition that bad. So, but when we find out all this, it will help us to make the patient feel. This does not end in the clinic. A low vision specialist can follow the patient to the home, where when we go there, we recommend readjustment of the seating arrangement, the furniture there, the lighting condition, the nature of the bulb there, their position, the intensity. We go to the house. Our work does not end in the clinic. We follow the patient home also and render our service there, where they can adjust the way the house is structured. So all these are part of our functional vision assessment. There are other things we look at: medical history, social history. And then we end our history taking by testing what we call realistic goals. After listening to the patients, you now try to find out, what does this patient really want? You have to hear from the patient what he wants. You have narrated to me how these problems that has made you to lose your job, how it is affecting you. Now, what do you want? This is very, very important, straightforward question. The person has to say what he wants. That is the goal. Now, this goal must be realistic. It must be realistic. So when the patient tells you he wants to start seeing 6/4, glaucoma, it's not possible. It's not possible. So the goal must be realistic. You can help the patient to adjust his or her goal. You direct him very well, make him understand his condition, that this C5 he is looking for is not possible. So the goal must be realistic. And then after our detailed history taking. What we do is to carry out what we call residual. Is an English word. We want to know what is. Then what eye problem made the vision to remain that level. We try to confirm the diagnosis of the primary eye care optometrist or the ophthalmologist that referred this patient to you. If in the referral note they said this patient has glaucoma, it is at this level now you confirm it and confirm the stage of the glaucoma. So in this exercise, we use dedicated tools like your visual acuity chart. You use visual acuity chart. You use ophthalmoscope. There are tools for dedicated tools for residual visual acuity. This is different from functional visual assessment. We have residual vision, we have functional vision. When we are assessing functional vision, the tools are not necessarily dedicated tools. They are not spelled out tools. You can easily improvise, carry out functional vision assessment. But for residual vision, ophthalmoscopy is done using ophthalmoscope. That is what we mean by dedicated tools. And then with this, we measure any structural loss in the patient. Visual acuity is the first assessment we do. We don't use the normal Snellen chart we have in the optometry clinic for our visual acuity measurement. For near vision, we make use of what we call the M chart, M notation chart. There is necessarily no fixed test distance. Our near GA is taken at 40 cm. Am I right? Hello?
We can hear you, sir.
Good.
We can hear you, sir. Continue, sir. I can hear you.
In our low vision clinic, our near vision is not necessarily taken at 40 cm. That is why I told you earlier on that low vision care adopt flexible protocol. It's not fixed. We don't say far is 6 meters, at near 40 cm. So the test must be carried out either at 6 meters or 40 cm. No. In low vision care, we can adjust the test distance. So near vision is not necessarily at 40 cm. We can take GA. What we are interested in is the distance where the patient was able to see something. Because this patient's vision is very, very low, and most of them assume that they are blind already. So, but when we make them see and able to read something that they were not able to read in the primary care optometrist office or in the ophthalmologist office, that is in ophthalmology office, they gave them near chart at 40 cm to read, and they are not able to see even N48. They can't see anything on the near chart. But when they come to the low vision clinic, we don't necessarily take the GA at 40 cm. We can take it very close to the face at 10 cm, 5 cm. So when we bring the chart even closer, and this patient is able to appreciate some things, that alone brings some level of psychological relief. It makes them know that, truly I am not blind. So I can even see something. So our near GA is not necessarily taken at 40 cm. So, and the chart we use mostly is the metric notation, not the one you have in the clinic. The one that says now we have reached the tree, the beautiful tree. There is no beautiful tree in low vision clinic. So then for the distance visual acuity measurement, we make use of the Lighthouse distance chart, which is based on early treatment diabetic retinopathy studies. That chart is better than the Snellen chart we have in the clinic. This discussion is we can't go into that discussion now. Why that chart is better than Snellen chart. But if you are interested, you can just pick up a form for low vision at the Nigerian Postgraduate College of Optometry. There you will know more why we make use of this chart and the other. But just for the purpose of this discussion, just know that in low vision clinic, we don't use Snellen chart there. Snellen chart has a lot of issues. So after VA measurements, we check for ocular alignment through what we call corneal reflex test. In corneal reflex test, we make use of the prism bar. Prism bar really to quantify the level of misalignment, either using the Krinsky technique or the Hirschberg method. Then the chart on the screen there, if Franklin can present it to you there, that's a picture of the Lighthouse early treatment diabetic retinopathy studies acuity chart we use in low vision. If you study that chart now, you see that it's different from the Snellen chart. Then lensometry. The way we do lensometry in low vision clinic is a bit different from the way it is done in primary optometry clinic, because most of these patients with low vision that have gone to some places, they've come with high-powered spectacles. Spectacles whose power is beyond the range that your lensometer can read. So your lensometer, I think what the maximum it can read is about 20 or 25 diopters that it can read, maximum. So if a patient comes with a spectacle of about 40 diopters, how do you read it? So in low vision here, we have a way that we can work on that lensometer so that we can extend the range that the lensometer can read. Likewise, keratometry. Keratometry is an objective measurement. We can use it to get clue about the patient's refractive error. We use it also to know whether the patient has problem with the cornea. Cornea plana, that is a highly flat cornea, is another condition that causes low vision. So with keratometer, we can find out if the patient has a problem with the cornea curvature. Things like a keratoconus, we can identify it using a keratometer. And the technique, it follows similar pattern, only with a little tweaking. We tweak the way it is done for low vision patients. Then after that, we carry out external examination. Most of these patients, before you carry out your external examination, you have to consider the patient's health and age status. Find out if the patient can sit in front of the slit lamp. If the patient cannot sit in front of slit lamp, you may have to carry out the external examination using a pen touch and magnifier. Then ophthalmoscopy is basically dilated ophthalmoscopy, where we make use of either, if you want to do direct ophthalmoscopy, it has to be dilated. If you want to carry out indilated ophthalmoscopy, you have to make use of either the Ruby lens or the Vogue lens to enable you to see every detail at the back of the eye. Remember that the goal is to know the level of eye problem. When we do ophthalmoscopy very, very well, and we find out that there is problem in some areas, assuming there is a macular problem, macular hole. There is a macular hole. Macular hole, there is little or nothing. If the ophthalmologist has tried to seal up the hole, and yet it's not possible. When we find out that this patient has macular hole, we try to find out the circumference, how wide is the hole, find out the part of the retina that is still healthy. Those areas of the retina that is still healthy can be harnessed in low vision care. We can redirect rays that are entering inside the eye away from that macular hole to a healthier part of the retina. So that's the essence of doing a detailed ophthalmoscopy to enable us to know the part of the retina that is still healthy. Then we do our refraction. We begin with retinoscopy. The way we do retinoscopy is a slightly different, a modified way of doing retinoscopy. The method we use is called radical retinoscopy. That's the technique of retinoscopy in low vision clinic, radical. It is done at a very close range, and then possibly total darkness. And when we are doing RET, we don't use trial frame. We don't use phoropter to do retinoscopy, because at times you may need to scope off axis. So we need to be flexible enough. So we make use of loose lenses. You hold the trial lens in your hand and you do the retinoscopy. So this is just a little way we tweak the normal way we do retinoscopy. And then the result we get from our retinoscopy is then refined through subjective refraction. The technique we make use of in refraction is called the bracketing technique. Bracketing technique, and then we make use of the patient's JND. JND means just noticeable difference. You need to find out the patient's JND using the patient's visual acuity. You can see that every step we take in vision is very, very important. So when you are taking your VA, you have to be very, very careful that the result you get in your VA is correct, because that value, the result of the VA, you can use it to determine your starting point in subjective refraction, just VA results. You can use the visual acuity result to determine the power of visual aids that you're going to give to your patient. So visual acuity is very, very important. So under JND, to determine the patient's JND, you simply take the denominator of the patient's 20 speed visual acuity. You know, our visual acuity is in fraction. 20 over, let's say 400. 20 over 400. The denominator there is 400. That 400, if you divide it by 100, that will give you 4. Am I correct?
Yes, sir.
So the denominator of the 20 feet visual acuity divided by 100, that will give you the patient's JND. So for this example I cited, the JND of this patient is 4 diopters. So you are going to start the refraction using +4 diopter lens. You put +4 diopter lens and compare it with -4 diopter lens. So if you check the difference from +4 to -4, it is very, very possible for the patient to dictate difference in clarity between -4 and +4. But if you have done the refraction the way we do it in our optometry clinic, where you start your refraction in 025 steps or highest 050 steps if you want to be fast. If you move from let's say from +2 to +150, the patient will not even detect anything. If you change lens, the patient won't even notice it, because this patient's error is very high, very, very high. So when you do the refraction small like that, the patient will not detect any difference. So we use the JND. JND makes it faster for us, and it makes the patient to be able to dictate differences in clarity between lens 1 and lens 2. That's the importance of JND. So you then bracket between +4 and -4, and then you build it up like that until you get to a point we call reversal. When you get a reversal, you will now be able to, that will help you to find out the precise refractive power that the patient needs. Then the next examination we do is perimetry, because a low vision patient, like we have defined, could have a visual field less than 10 degrees. So in low vision care, we try to find out the patient's visual field. And the method we use could be with Amphlatart. Yes, we use Amphlatart for central visual acuity measurement. So if you are not familiar with ampular chart, you have to make sure you familiarize yourself with it. In low vision care, we don't start afresh to teach you how to use ampular chart. So we use the ampular chart for central visual field. We can also use the automated perimeter for both central visual field test and peripheral visual field test. So when you carry out this assessment, you'll be able to find out what is wrong with your patient, the structural loss that led to the patient's handicap. You'll be able to find out that and then prepare for your patient's rehabilitation. Quickly, then you carry out what we call a functional visual assessment. Functional vision simply means vision used for a particular purpose. If you are a driver, the vision that you use for driving is your functional vision. If you are a tailor, that vision that is needed for tailoring work is your functional vision. So somebody with good visual acuity who cannot do his tailoring job has good residual vision, but functionally has poor functional vision. So at that point, now the low vision specialist has to now work on the patient's functional vision. We have to do something to enable this patient who is a tailor to continue the tailoring job. Functional vision assessment is not conducted with any special tool. Just like we have retinoscopies for retinoscope. In functional vision assessment, we don't have any dedicated tool for functional vision assessment. Are we following?
Yes, sir, we are following. Right on.
Yes, sir, we are following.
Yes, you can proceed,
Functional vision
sir.
Thank you. Functional vision assessment is done in two parts. First, we try to observe the patient, observe for the effect of low vision on the patient. Here, we check how the
Yes,
patient
sir.
feels about his condition. You are employed some level of psychology.
Yes, sir, we are
Some
here.
level of psychology. Some level of psychology to know how the patient feels about his vision. We try to find out how does the patient use his vision. For instance, there are patients with scanning. Some people, they use the side of their eye. When you give them something to read, they position it somehow. They don't keep it straight to see. So we try to find out, we observe this patient for how he uses vision. Does he tilt his head? Does he tilt his head? Does he tilt his eye? Does he assume any special posture when doing his activity? All these observations are part of a functional vision assessment. So we try to find out also whether there is need for modification of the patient's environment, such as lighting. So in this functional vision assessment, we test for filters. There are things we call filters. We have gray filters, we have yellow filters, we have many of them. We test them for filters at this level to know whether there is need to adjust the type of light the patient has been using. We check also for effect of contrast on the patient's vision. And then color as well. We check for color as well. Then the second part of the assessment is where we check for skills that the patient uses for functioning. Skills, some visual skills. This includes awareness and attention to objects. We check for this. Is the patient aware that there is an object in front of him? Does he pay attention to an object? If an object is moved to the side, does the patient switch attention to it, or the patient does not even switch attention? Then we check how this patient controls eye movement. things like tracking and scanning. When you put something in front of him, can the person scan? Scanning is to enable the person pick up fixation. So we check this scanning and tracking technique under functional vision assessment. And then next, we check for a person's ability to discriminate objects. Discriminating objects means seeing the object as a particular object and not the other way. Then we check for discrimination of details and ability to identify and match objects. All this part might look a bit more technical for us now, but when you come into low vision, you will enjoy it. It's quite easy to comprehend. Then, in our clinic, after we must have done both residual visual assessments and functional visual assessment, the next thing we do is to manage the condition. Low vision management is not a one-man show. It requires input from different experts. So if you have a low vision clinic, if I establish one today now in Owerri, I may not be able to help my low vision patient completely without involving other experts. So low vision care involves the low vision specialist, it involves the orthoptist, it involves a social worker. You will have to involve also mobility experts. So you need also to carry along your ophthalmologist, because the problem cannot be solely addressed by a low vision specialist. So when this team of experts bring in their wealth of knowledge, you can see that the patient will start functioning better. So now, to manage the patient, this team helps to identify the problem, carry out needs assessment. What does this patient need? And then they now team up to tailor the rehabilitation goal, find out the goal we need to pay more attention to. Patient can have more than one specific need. So you have to tailor it, find out the one that is most important and realistic. So this team of experts help put their heads together to decide how to handle this patient. Does this patient require optical aid or non-optical aid? Now, the aids or the treatments we give to low vision specialists is classified into two: optical and non-optical. Optical aids is of value to people with conditions like albinism, people that benefit from optical aids. When we say optical aids, we are talking about things that have refractive power. We are talking about things like lenses, mirrors, prisms, magnifiers, telescopes. These are optical aids. So the conditions that benefit from these optical aids include albinism, central serous retinopathy, high refractive error, micro-ophthalmos, and diabetic retinopathy. But for conditions like retinitis pigmentosa, end-stage glaucoma, optic atrophy, retinal vascular occlusion, macular dystrophy, these conditions may not benefit significantly from optical aids. So we help these patients using non-optical devices. So the available treatment options we have, the way we help this person is by increasing brightness of the image, increasing or improving contrast, enlarging the image, the retinal image. These are the techniques, the three main techniques we use for helping patients with low vision. One, increasing the brightness of the image, improving the contrast of what they are looking at, and then enlarging the retinal image. In fact, we classify this into 3D: bold, bolder, brighter, and bigger. Bolder, brighter, and brighter, bolder, and bigger. 3D. So these 3D, you achieve it by these three approaches: increasing brightness, increasing contrast, and then enlarging the retinal image. These three modalities achieve. Hello?
We can hear you, sir. We can hear you.
Can achieve the 3D by a combination of these techniques. One, you have to correct any refractive error the patient has. It has to be corrected. Then occlusion therapy, you need to occlude the eye for patients with severe diplopia, where the two eyes cannot unify image. In that case, the best thing now is to occlude one of the eyes so that patients will be making use of the other eye. It is better to have one functional eye, one functional and a comfortable eye, that have two eyes that are problematic. So occlusion therapy for people with severe diplopia. Then we have enhancement of oculomotor skills. This is where we train our low vision patients for tracking and scanning. This one is an in-clinic something where they come regularly for training. Together with the orthoptist, you train them for scanning and tracking. Then light manipulation, I've talked about this. You manipulate, you change, you modify the lighting condition where these patients operate. Then magnification. Modifying the lighting condition could be by changing the nature of the bulb, the electric bulb in the house. It can also by giving the patient special filters that can enable them see better. Then magnification. Magnification means making what the patients read or see to look bigger. And then finally, visual field restitution. Patients with visual field problem, let's assume hemianopsia, they have lost one side of their visual field. Do you know we can relocate objects that fall within their blind spots, that area that they cannot see? We can relocate the image in that region to the seeing part of the visual field. So when we do this, we call it field restitution. So despite the patient having the anatomical defects in the visual pathway, we can use special freezing to relocate objects away from that region that is blind to region in. So the patient's anatomical defect is there, but this patient can still operate, can still walk with that eye problem. This is low vision for you. Then, under non-optical aids include large prints. If the patient is a pastor and has problem with tiny prints, you can switch the patient from small Bible to a bigger Bible. Then we have what we call reading stand. Reading stand helps the patient's posture because most of them with low vision usually assume awkward posture in order to see. You see them forcing themselves, training to see something. So, but when we provide them reading stand, it helps them assume better posture. A reading stand from the explanation is non-optical. So that's why we call them non-optical. Large book, telling the patient to buy a bigger Bible is non-optical. Then illumination devices like fluorescent bulb, glare control devices like changing the bulb, the nature of the bulb in the house to another one is non-optical because it has no refractive power. Then we have writing devices that we recommend, we prescribe for low vision patients. We have a typoscope. I don't know if I have a picture of typoscope here. No, I don't have it. So we have typoscope that we give. Mobility cane for moving around. I don't know if you have seen someone that is blind along the road with a cane moving. That low vision patient was trained on how to use mobility cane. With mobility cane, the patient can trek from his house to the market to go and buy something. So mobility cane is non-optical. Then we have sensory substitution. Since this patient's vision is now very poor, we can now convert those things that require sight to auditory stimulus. Example is talking books. A book that will be that talks, that it will tell you what is written on it. We have clock. If it is 1 o'clock, the clock will announce the time now is 1 o'clock. Since this person cannot use the eye to appreciate the clock, with the ear now, the person can function. So recommending that the person change his work clock to talking clock or watch is a way of rehabilitating these patients. We have calculators that make sound. So this we call it sensory substitution. Then we have a special kind of pen that we recommend for low vision patients. This pen that we call felt tip pen makes special bold mark. Is the mark it makes is better than the one that your biro makes. So it's part of the things we recommend for our patients. Then signature guide. We dispense signature guide. It helps them guide them on where to sign. To have no text, we have a table and a floor lamp. Floor lamps to see better when they are ascending or descending the staircase. Then in the kitchen, we have some special kitchen tools that can enable them to return back to cooking. Those of them that have left cooking because of their sight. We can recommend finger cap guides. You can see it in the picture. You can see this patient, a low vision patient, trying to cut vegetable. With this finger guide, the patient will be able to cut vegetable without cutting his or her hand. Then we have a spoon and measuring cup. What is special about this is the color and the contrast of this set of spoons and cups to help the patient in the kitchen. Then for them to take their drugs, we have a bump dog. This helps them to identify where tablet is and in order to pick it up. Then we have a liquid level indicator with an auditory to alert the patient when the cup is nearly full. So these are things. So instead of the regular cup in the kitchen, the patient goes home with this, and then as he's pouring tea or water into the cup, once the is getting to the tea, it will make a sound, an alarm to alert the patient that this hot water, the water level is full. The low vision patient. So all these are non-optical aids that we can recommend for our patient. Then for the optical devices, these are devices that have refractive power. They are devices that can reflect light, refract light, and disperse light. We call them optical devices. So we have them. We have handheld monocular and binocular telescopes. Telescope is for improving distance vision. Magnifier, hand magnifier, stand magnifier. So one thing I want us to understand about optical aids is that they are task specific. Optical aids are task specific. You cannot use an optical aid that is for sighting. You can't use it for near work. Neither can you use your hand magnifier that is for near reading. You cannot use it to work. Aids are task specific. It might have up to 5-10 different aids. So this is one problem we have in low vision today. This makes low vision care very, very expensive. Because these optical aids you see displayed on your screen there are very, very expensive. So imagine the person getting each of them one. So that's one limitation we have in low vision. So we have our telemicroscopic spectacle for near work. Then we have reverse telescope. Telescope is for distance vision. Then when you turn the telescope, when you turn it, instead of the eyepiece facing your eye, facing you, you have reversed the telescope. With that, with that reverse telescope, the visual field can be minified. This device now is for field restitution, tunnel vision. A glaucoma patient with tunnel vision that has lost the side vision. So those the scotoma regions, if you give them reverse telescope, it will reduce, it will compress the person's visual field so that more objects will tunnel, that's remaining tunnel. Then we also have special prisms. Prisms are for expanding the patient's visual field. So they are depending on the nature of the patient's problem. You will know whether the patient needs to strengthen the visual field, like somebody with tunnel vision. In this case, you need to compress what is in his environment to fall or fit into the tunnel vision that is remaining. You do, and then for those that need their visual field to be expanded, we can do this using special prisms. And the way you position this prism is that the base of the prism has to be on the side of the defect. So if a patient has right, the base will face the right on that same side. Put the base on that same right. When you position the base that way, all objects that are within that blind right hand side, all of them will appear towards the apex of the prism. So this is the way you can use to transfer objects within the blind spot into the seeing part of the visual field. So we have them in the picture there. You can see a patient with a unilateral sector prism. Unilateral in the sense that the prism is in just one eye. Is in one eye. You can see the base of the prism. The base is the thick part of the prism. So we have it there. Then you have the one the patient is wearing. That one is called Fresnel prism. That letter S is silent. Fresnel prism. You can also use it. So you can see the white man there with the Fresnel prism. When the patient wants to spot something, the part up and down there is the Fresnel prism. Fresnel prism is like a sellotape. That's how the prism is. It's like sellotape. You can detach it from the spectacle. So this patient, if he wants to view towards that side that has defect, he will look into it. Otherwise, he will look straight. When he's looking straight, if the prism is not within his sight. So these are some strategies we use for helping our patients with low vision. Are we there?
Yes, sir, we are here. We are here, sir.
We are here with you, sir.
Okay, thank you.
Yes, sir, we are with you.
Thank you so much. I conclude this discussion tonight by saying that low vision is a chronic eye condition that can only be helped by rehabilitation. Rehabilitation means making this patient to still be able to function despite having the eye condition. Rehabilitation requires multidisciplinary approach. Low vision care is a teamwork exercise. And then with proper application of technology, the residual vision, the remaining vision of a low vision patient, in order to improve their quality of life. The major problem of low vision patients is that it affects their productivity. It affects their quality of life. Most of them are now dependent. Many have lost their job. Many cannot wear their clothes on their own. Many can no longer cook. Many cannot walk into the bathroom on their own. So, but when we apply technology, we can help them to use that. We can improve it, and then to improve their productivity and quality of life. I want to thank you for listening to this lecture. Thank you very much.
Oh, thank you so much, sir, to the highly esteemed Dr. Ekenze. Thank you so much. It was captivating.
Thank you, sir. Thank you.
Don't forget to like, subscribe, and comment on our YouTube platform on OSAF. Watch, and then if you have any question, like I said earlier, do well to send them on the OSAF national platform. The leaders will collate it and then forward it to Dr. Ekenze. After he answers them, we'll send them back to you. Thank you so much for joining us. Have a good night rest. We hope to see you in our next edition coming up very soon. Good night.